Well, we'll go ahead and get started. It's a little after 12:30. This is Dr. Nina Fertitta. She's one of our chief residents this year, and she's here to do her grand rounds on intimate partner violence and sexual assault, something that's certainly very important to all of us, and we need to stay up to date, know what to do, and how to help. So, Dr. Fertitta.
Okay, so, which I was unaware of it, but it is really important. I was talking with Dr. GYN yesterday, and she said she actually had one of these cases on her boards, her oral boards, where the lady presented, or the scenario was there was a lady that was in her middle ages, and she came in with her complaint of being tired and having a decreased libido, and they wanted her differential diagnosis. She listed several different things about like organic causes, psychiatric causes, and then finally she was like, oh yeah, domestic violence. And then of course the next question follow-up was, when you go to examine her, she has bruises, now what do you do? And as Dr. GYN told me, she said, I wish your lecture was earlier, because after the refer them to a social worker, it was really hard for me to come up with what else to do, what other things should we be concerned about. So I'm glad I'm giving this now. So if anybody knows who these people are, the one on the left is Ray Rice, and he was a running back for the Baltimore Ravens and was caught recently on videotape punching his then fiance to the point where she lost consciousness in an elevator. So this is, and then the one on the right is Emma Roberts. She is the niece of Julia Roberts. She is also an actress. So she was picked up in Montreal in 2013 after she had an altercation with her boyfriend in a hotel, and he was full of bruises when the police showed up. So it can happen to men as well as women. And we should always, you know, keep this in mind, because it's not just our patient population, the indigent population. It can occur in every age group, socioeconomic class, ethnicity, gender identities, and any sexual preferences. So to understand intimate partner violence, we should define it first. So intimate partner violence describes any physical, sexual, psychological harm by a current or former partner or spouse, and this type of violence can occur among heterosexual, homosexual couples. It doesn't discriminate. So physical violence is the intentional use of physical force to cause harm. This is the most commonly thought of form of domestic violence, but there are other forms as well, such as sexual violence, and this is divided into three categories. The first is the use of physical force to compel a person to engage in a sexual act against his or her will, whether or not that act is completed. The second type is attempted or completed sexual acts involving a person who is unable to understand the nature or condition of the act, and they cannot decline or participate or communicate an unwillingness to engage in the sexual act. This could be because of illness, disability, influence of alcohol or other drugs, or a mental condition, or just sheer intimidation or peer pressure. And then finally, there's abusive sexual contact, such as rape. The threats of physical and sexual violence can precede the act. So at any point, these can include words, gestures, the use of weapons to communicate the intent to cause death, harm, or any kind of physical injury. There is psychological and emotional violence that can occur inside or outside of the home. This is probably the most pervasive because the trauma to the victim is caused through acts, threats of acts, or coercive tactics to control their partner. For example, the perpetrator can use name calling, humiliation in public venues, control of their finances, control of the victim's time by controlling who they spend their time with, whether that be family, friends, or denying the partner to go to work outside of the home. So the cycle of violence occurs when the tension starts to build between the perpetrator and the victim until there becomes a point where there's an acute burst of anger resulting in any form of violence, and then that is always usually shortly thereafter followed by feelings of guilt by the perpetrator, and then asks for forgiveness and makes promises that this will never occur again. So, as mentioned before, women are more likely than men to experience domestic violence, but men can have domestic violence occur to them as well. Women have a rate of 1 in 4. This will account for approximately 1.3 million women to become victims of physical assault by an intimate partner each year. And the females that are aged 20 to 24, which are a lot of our clinic patients, are at the greatest risk for non-fatal intimate partner violence. And the key thing is that most of the time, these are not reported to the police. And before the presentation, Dr. Buchholz asked, are we required to report this to the police? And this is different than child abuse. If the patient does not want to report the violence, then we are not required, nor do we have the jurisdiction to report the partner. Okay. So, although women are the most common group affected by intimate partner violence, there are special populations that should always be considered. Pregnancy is a big risk factor and is a unique population in that is sometimes the way that the perpetrator will use to control their victims, by sabotaging birth control to cause pregnancy, or by not allowing the victim to take birth control, and then they will blame the victim for becoming pregnant and causing a strain on the relationship and therefore increasing the violence. Immigrants sometimes come from cultures and countries that do not consider domestic violence as a crime. So when they come to this country, sometimes these victims do not realize that there's anything that they can do or change, or that anybody would be willing to help them, so they keep quiet. Disabled women, or disabled men for that matter, including the mentally handicapped, physically handicapped persons, may not be able to defend themselves or be able to talk to people and disclose what is occurring to them. And so this can allow the abuse to go undiscovered. So, like the handicapped individuals, also elderly sometimes may not be able to disclose their abuse because of they might be a close family member, such as an adult child, and they're ashamed of the fact that their children would be having violence against them or abusing their finances in a way to control the adult. And they also may have signs of dementia or declining memory, so they may not understand or realize shortly after what has happened, or be able to recall specific events when they are questioned. And then finally, the group that's probably the most unrecognized is men. Because most of the time when we talk about domestic violence, intimate partner violence, the man is usually portrayed as the perpetrator and not the victim. But we should always remember that men too can become victims of intimate partner violence. So although most children that live in a house with domestic abuse also experience abuse themselves, just the act of witnessing domestic violence can cause an imprint on the child that the abuse is not morally wrong, and therefore continues the cycle of abuse, especially in boys. they are 2 times likely to become abusers than are girls. So in the recent publication of Child Abuse and Neglect, the article Subtypes of Exposure to Intimate Partner Violence Within a Canadian Child Welfare Sample, Associated Risk and Child Maladjustment, the main focus was to examine the association between subtypes of intimate partner violence exposure on child functioning and presence of harm within the child welfare system. They used the Canadian Incident Study of Reported Child Abuse and Neglect from the year 2008, which gave them a population of 2,148 children, and they looked at specific types of intimate partner violence exposure, including physical and emotional violence and other household risk factors. And they concluded that children exposed to physical intimate partner violence and emotional intimate partner violence had the greatest risk for internalizing problems and presence of harm in the future. And the study solidified the fact that exposure to intimate partner violence is one of the greatest risk factors for intimate partner violence in the future, and that specific behavior can be learned from their adult caretakers. So even though exposure to intimate partner violence as a child increases the risk for that child to develop intimate partner violence behaviors, it is not the largest risk factor. The largest risk factor is regular alcohol abuse and drug abuse. This can not only increases the risk of domestic violence, but it also increases the risk of greater harm when those episodes occur. So in the Journal of Studies on Alcohol and Drugs, this presented the article Husband and Wife Alcohol Use as Independent or Interactive Predictors of Intimate Partner Violence. And they looked not only at the husband's use of alcohol, but also the wife's use of alcohol and how it related to intimate partner violence. If both partners had alcohol dependent symptoms and consumed large quantities of alcohol, this contributed to the likelihood and frequency of the husband to perpetrate intimate partner violence. If the husband alone had alcohol dependence, this contributed to the occurrence of the wife being the perpetrator of intimate partner violence. But then if the couples neither were heavy drinkers, it showed that there was really no increased likelihood for either partner to participate in intimate partner violence. And so I also looked at the use of drugs, and marijuana is one of the most commonly used drugs. And I decided if alcohol dependence increases likelihood, then maybe marijuana would as well. But on the article by Psychology and Addictive Behaviors, they showed that marijuana use is inversely affected intimate partner violence. Marijuana use by both partners Okay, so if both partners or just the husband alone used marijuana, there was less frequent perpetration of intimate partner violence by the husband. If the wife used marijuana, there was an increase for intimate partner violence, but only if the wife used 1 year prior to the start of their marriage. Okay. So when a patient presents to clinic and there's possibly evidence on the history taking or during the physical exam that this woman is a victim of intimate partner violence, what should we do then? So the things that are keys to look for and to watch out for is if the patient has any history or physical findings that are inconsistent with what they're telling you, if they're reluctant to be examined, if they are not using their medications as prescribed, and if also they have delay in seeking treatment of any form. Specifically with the pregnant population, these women will usually have late entry into prenatal care. They will have an inappropriate affect where this is usually a happy time in a woman's life that she's pregnant. They will be sullen or just have a flat affect. They may actually visit triage or ER more often than they actually come to their prenatal care appointments and instead of coming. There's also associated psychological conditions that occur after intimate partner violence, including depression and suicidal ideations. This usually comes because of the constant irregularities in the cycle of violence. The victim feels that they no longer deserve to live, or they feel ashamed of what happened, or that they have no way out of their situation, and that this the only way to leave their situation is to physically leave by suicide. Some will start to indulge in illegal or legal substances that we give them to try to escape their circumstances. Others will have anxiety, panic attacks, PTSD, and other dissociative disorders just related to the repeated cycles of violence that they endure. And psychological conditions are not the only thing that can occur to these women. They can also have physical gynecological disorders such as premenstrual syndrome. They can have repeated STDs from their partner, who then tells them that they're the cause of the STDs in the relationship, which escalates violence. They can have unintended pregnancies from reproductive coercions like before, when they're told that they can't take birth control, or their birth control is sabotaged or taken away from them. And finally, our favorite topic, they can have chronic pelvic pain, and it's mostly just kind of a referral because of all of the abuse that occurs. So how else, besides just asking the patients and trying to be attuned to physical domestic violence, can we pick up on these patients? So one of the easiest screening tools is called the HITS tool. It's 4 simple questions. You can place this in the waiting area or in the bathroom so that the patient can read it quickly, add up their score. If they have a score greater than 10, then it's a positive score for a possible victimization, and they should be then told to inquire with the physician about what else to do. The HITS questionnaire just ask, has your partner ever physically hurt you, insulted or talked down to you, threaten you with harm, or scream or curse at you? So it's something that can occur very quickly. You can ask. So if someone did have 10 or greater on that, and they can't come in, how should you assess them? So first off, you should start always with open-ended questions. Allow the patient to disclose as much as they would like. They do not have to disclose everything. This can be an ongoing process, especially as they become more familiar with you. You create a bond and trust with that patient. They will be more likely to tell you more of what's going on. You should always place these patients in a private room if they have someone with them, because most of the time their attackers or abusers will be with them. You can ask them to leave the room that you needed to have a conversation with the patient, or say that you would need to examine them alone, and that way you can get them alone from their attacker so you can ask them. You always need to assure the utmost confidentiality so that you can gain their trust. And just always assure these patients that whatever the circumstances, that abuse and violence is never their fault and is always undisturbed. So another screening tool that just I thought, not necessarily for screening the patients, but something we should have in the back of our mind, is called RADAR. It was developed by the Massachusetts Medical Society in 1992. It's been since then adopted by many medical, legal, mental health organizations. The keys to the RADAR tool are that it should keep practitioners' minds focused on what's important. You should always remember to routinely ask your patients about intimate partner violence. If they state any or have any indication that this may be occurring to them, you should ask direct questions about them and allow them to talk openly and freely. You should always document your findings in a note so that it will be there in their record. And at that time, you should also assess their current safety. If they do not have, they feel like it's still safe for them to go home or they're not ready to leave, then you need to give them avenues such as support groups, shelters, things like that, plans for them to leave if they need to. And then always you need to just keep bringing this up if someone indicates that they have domestic abuse in their relationship. The SAFE tool is also kind of like the RADAR tool, but I put it up here just as another example if it's easier for you to remember SAFE rather than RADAR. SAFE ask about the severity of abuse, you question their fear and isolation, and then again give them options as to how to follow up, where to go if they need help, that kind of thing. So then finally, since we've talked about the medical aspect of intimate partner violence, just a quick slide on what it costs society. So intimate partner violence exceeds approximately $8.3 billion, and that's only about half of it as medical or mental health expenses, because we also have to add in loss of productivity, whether that's time away from their job, need for them to stay home with their children, or have to pay for additional child care options. And on average, the health care cost of each incident is approximately $948 for a woman, and for a man it costs about $387. So sexual assault, this could be like a topic all by itself, but it is also very important because it is a common aspect of intimate partner violence as well. So sexual assault can occur in approximately 40 to 45% of battering relationships, and that accounts for about 2/3 of the sexual assaults occur because the patient, or the victim rather, knows their assailant. And approximately 1 in 6 women and 1 in 33 men will have either experienced an attempted or a completed rape in their lifetime. The most common ages for an attempted rape or sexual assault is between the ages of 12 and 34 years, with the highest risk in girls ages 16 to 19. They are 4 times as likely as the general population to become victims of sexual assault. So, if we ever have a victim of a sexual assault that presents to clinic, or if you have to examine them or interview the victim, most of the interviewing points are the same as you would with an intimate partner violence. You want to create a safe environment for this victim, but there's specific things that you should remember. Most of all, you need to ask about the circumstances surrounding the assault, including the date, the time, location. Was there any use of weapons or force, restraints, any threats that occurred before or after the assault? whether the victim experienced any loss of consciousness during the assault and may not be able to remember all of the details. They need to try to get as many of the assailant's physical characteristics from the victim, whether they have tattoos, scars, anything that could identify the assailant. You should also ask about if there were any use of drugs or alcohol, whether it was consensual use of these things before the sexual assault, or if they were drugged in an unknowing manner. You need to ask about the specifics of the actual assault, whether it was only oral, sexual, if there was any vaginal or anal penetration, or any trauma that occurred, any bleeding that occurred on the side of the victim, or if they noticed any bleeding on the side of the assailant. And then always you need to ask about, was there any recent consensual sexual activity that surrounded this event, which may blur any pictures during a physical exam. So most of us will never ever perform a physical exam on a sexual assault victim. This should always be performed by a forensic nurse who is specifically trained in doing this, because the collection of evidence has to follow a chain of command, and they're specifically trained to do that. They have specific kits that they use, and they have specific checklists that they go through so that they are not missing anything. But you should always refer these people. Usually the forensic nurses come to the ER, so you should refer before you do any physical exam or may contaminate any evidence. Refer them to the ER so that they can be examined by a forensic nurse. Physical exam is always more helpful within the first 72 hours of assault. That way you can still see physical injuries or abrasions, and they use the acronym TEARS, which stands for tears, any breaks or fissures in the skin or lacerations, ecchymosis, abrasions, redness, and swelling. Also, the use of a colposcope can add in collecting evidence, especially with there's milder genital or anal trauma. You can use a Woods lamp as another UV source to collect any semen or debris on the skin. Also, in some states, they allow the use of toluidine glue dye to help identify any area of trauma that can occur. Also, they have to get the specific permission from the patient to collect any photographic evidence of bruises, tears, abrasions, anything like that. If it is a male victim, they need to pay specific attention to the penis, the scrotum, and especially perform a very thorough rectal exam. So in some cases, they can bring an actual perpetrator or suspected perpetrator of a sexual assault to an ER to be examined. The physical exam of a perpetrator is basically the same as the victim. You can ask them about their history, but because it's a ongoing investigation, they still have the right to remain silent, so they do not have to answer any of your questions. They can answer some of them or none of them. But you should always document important things such as the areas of any trauma or harm that is on their bodies, any permanent identifying marks such as tattoos and scars. You should always get labs on these patients, including an STD panel, UDS, alcohol levels. And the most important thing is if, for instance, a victim happens to be in the ER at the same time, the police may bring the suspected perpetrator. These people should always be examined in separate areas, kept away from each other. That way the victim can feel safe from the attacker and also keep the victim's anonymity intact. So parts of the forensics exam, the most important thing is that forensic collections decrease with the time that passes, and also with any specific behaviors that the victim may perform right after the assault, which may include taking a bath, changing clothes, brushing their teeth, just trying to clean themselves. That can always decrease the amount of evidence. But even if any of these things happened or it was a longer amount of time before they presented to the ER, you should at least try, because with the development of new technologies, any little bit of evidence may still be present and can actually help in the case that they're building, that the police is building. So things that you can do that usually patients don't think about cleaning. You can get vaginal swabs, you can get saliva swabs, you can get hair from the scalp or the pubic area. You can get any kind of fingernail scrapings or clippings from the patient. And also you can get blood samples as well, and urine samples. So in some testing, you need to perform just in the areas of correct and appropriate medical care at that time, which include x-rays, because there may be broken bones that need to be set. But you also need to be aware of the things that you order, because sometimes they're not exactly required in that moment to treat the patient. You can either give them prophylaxis instead. So in the area of STDs, patients do not need to be treated right at that moment. They can be given prophylaxis, because if they did test positive, they can have that actually go against them. The prosecutor may say, or rather the defense attorney might use that as, this patient is promiscuous, she had gonorrhea and chlamydia, that shouldn't show up the same day that they come. If they came on the same day as the sexual assault occurred, that this was a consensual thing, not a rape. Also with UDSs, there may have been any illegal substances that were used, and even if you're just looking for like date rape drugs like Rohypnol or DHB, if something came up like cocaine, then that can be used to discredit the patient. But finally, you should always, no matter when they show up, offer them a pregnancy test. So you should properly treat all fractures, soft tissue injuries. Sometimes these would necessitate a hospitalization, even if it's just for to observe them overnight, pain control, that kind of issue. If they're allowed to go home from the ER or when they're discharged, you should give them quick follow-up. Within a week, you should always give them empiric treatment for at least gonorrhea, chlamydia, and trichomonas, which is, as we all know, azithromycin 1 gram PO, 250 milligrams of Rocephin IM, and 2 grams of Flagyl PO. If you need to counsel them before giving them prophylaxis for hepatitis B, if they know that they have immunity to hepatitis B, you don't need to do anything. If they don't know if they have immunity and they opt for prophylaxis against hepatitis B, you should give them the hepatitis B immunoglobulin and the first round in the series of the Hep B vaccines. Also with HIV, there needs to be a significant amount of counseling performed before you place someone on HIV regimens for prophylaxis. The CDC does not recommend at this time even offering prophylaxis for HIV if the victim presents over 72 hours after the initial assault, but they need to be counseled about side effects, about the possibility of still having the disease, and then the patient may even decline the prophylaxis. You should also discuss with them their chances for contracting HIV from one single sexual assault. We don't have actual numbers on this, but we go off of the numbers that from consensual sex, which are still very, very low, between 0.5 and 3% for male to male contact and lower for male to female contact. It's between 0.5 and 1.5% for male to female. Of course, we think that these risks increase if there's any kind of possibility for blood transmission through trauma or lacerations. So pregnancy, the risk is, again, very low. There are no numbers on how often this occurs because there's always changes in menstrual cycles in women. There's irregularities in ovulation. There's a possibility that the victim was already on birth control at the time of the attacker. The attacker may even use a condom, or because it's an act of control and not of sexual pleasure, they may never actually ejaculate. So the risk of pregnancy is low, but in any case, you can offer emergency contraception. Its greatest effect is within 72 hours after the unprotected intercourse, but can be offered up to 120 hours afterwards. The key thing in remembering about all of these prophylaxis, if the patient decides to take all of it, is that it can cause severe nausea and vomiting. So if they choose to take all of this, you should always give them Zofran or Phenergan beforehand so that they do not thereafter throw up all of the medication. And those are just, those are the different forms of emergency contraceptions. You can use either the combined estrogen or progesterone only, or antiprogesterones, which are available in some states but not all states. So in the short-term follow-up, like I said, they should be given a quick follow-up within 1 week, but definitely do not wait more than 2 weeks, because with the length of time that it occurs after their initial presentation, their follow-up declines. On that follow-up though, you should always offer them any repeat STD screening. If they only took prophylaxis at that time and they decided to get screened at that visit, you should allow for that to happen. They also should get repeat RPRs and HIV regardless at 6 weeks, 3 months, and 6 months after the event. And you should also perform a pregnancy test again. And finally, the biggest thing about their follow-up visit is you need to assess their psychosocial symptoms, whether they're having insomnia, anxiety, fear, and then relate that to the appropriate caretaker, whether that be psychiatry or just a support group for them. So like I said, the acute issues include fear, anxiety, anorexia, insomnia, shame, guilt, intrusive thoughts. But if we as providers do not address these in the short term, they can turn into long-term issues, including PTSD, depression, and anxiety disorders. So we should always be highly aware of these issues and that they're at specific risk for developing these disorders. The long-term effects of sexual assault will always come from any remaining psych issues, which can lead to drug abuse, prescription or non-prescription, poor follow-up, with any medical screenings, especially the GYN screenings. So these women are at an increased risk for cervical cancer and STDs because they will decline pelvic examinations. And also they have an increased risk for decreased sexual satisfactions in their future relationships and decreased libido, which this may actually cause friction or with their partners and may cause worsening of violence if there is that possibility. So the resources we have in town, the biggest one is the Providence House. They take women and children in who are homeless and victims of abuse, and they help them restart a new life, whether that's find a job, become educated, or get a new apartment. Some women leave their abusers with nothing except for the clothes on their backs. They have no money, no checking accounts, nothing, and the Providence House helps with all of that. The next one is Project Celebration. This one's actually in Manny, Louisiana, and I was unaware of this one, and there's not a lot on the internet about it. We got it from our social worker, but they also kind of have a safe house for abused women and children. Here's the phone number for the domestic violence unit for the Shreveport Police. And you can give out these hotlines. There's local ones and national ones. These are my references. Any questions? Right. Oh, okay. Thank you.